Greetings, my name is Laith Jamil from Cedars-Sinai Medical Center, Los Angeles, California. On behalf of my co-authors, Amir Kashani, Naveen Peter, and Simon Lowe, I'd like to discuss briefly our upcoming article published in Gastrointestinal Endoscopy titled Safety and Efficacy of Cap-Assisted Endoscopic Mucosal Resection for Sporadic Nonampullary Duodenal Adenoma. We felt it was important to publish our experience of removal of duodenal adenomas using this technique, given the high rate of malignant transformation of duodenal adenomas. The technique, which is described in our article, involves the use of a transparent, straight cap and a crescent snare. The study population included 42 patients with 49 sporadic nonampullary duodenal adenomas. 10 polyps were able to be removed en bloc, and the rest were removed in piecemeal fashion. Some of these polyps required more than one session to be removed, and this was planned because of their size and location. Thus, the eradication rate was approximately 81% on the first session, 87.5% for polyps removed in piecemeal fashion, and 90.5% for all polyps. Patients with a residual adenoma who came back for follow-up, we were able to remove the residual adenoma, thus resulting in a 100% ultimate eradication rate. There was about a 7% major complication, with 3 patients having delayed bleeding that was treated endoscopically, and 1 patient with a delayed perforation that was also treated endoscopically. Thus, when you compare these results to results of other endoscopic mucosal resection techniques for duodenal adenomas, they seem to be fairly comparable and better than the surgical outcome, with less morbidity, less mortality, and less recurrence compared to local surgical resection of duodenal adenomas. We believe this technique allows the endoscopist to delineate the margins of the polyp better, and when performing endoscopic mucosal resection, the endoscopist will be able to include a rim of normal epithelium to minimize residual adenoma. The use of the cap for removal of adenomas has been described by others and by us for colon polyps and for duodenal adenomas. We would recommend, prior to using this technique for removal of duodenal adenomas, that the endoscopist try this technique in polyps in the stomach and rectum, and then maybe proceed to polyps or adenomas in the esophagus and left colon prior to considering this technique for adenomas in the right colon or cecum or in the duodenum. Some practical tips on minimizing the risk of adverse events would be obtaining an adequate submucosal injection, decreasing the suction power on the scope to about half to minimize the risk of suctioning the musculus propria into the cap, and thus minimizing the risk of a perforation. Thus, our study adds to the body of literature on the safety and efficacy of endoscopic removal of sporadic nonampullary duodenal adenomas. Hopefully in the future we will see prospective studies or randomized trials comparing different endoscopic modalities on removal of duodenal adenomas. I'd like to thank you for viewing and invite you to read the entire article in GIE, Safety and Efficacy of Cap-Assisted EMR for Sporadic Nonampullary Duodenal Adenoma. Thank you.